You're going to have to now stop talking in the back, and if you're interested in electrophysiology, electrograms, pay attention. If not, maybe just think about the case of arrhythmogenic cardiomyopathy in a young man, and see what we do with these patients today. So I've been tasked to talk about mapping and ablation of VT in this patient population. So we have a 24-year-old man, previously fit and healthy, presents about a year and a half ago with sustained monomorphic VT associated with dizziness. It occurred while he was exercising. Here's his ECG. I have to say it's not very remarkable, but if you look at leads V1, V2, and V3, definitely abnormal, right? You can have the infantile pattern of maybe V1 and V2 of T-wave inversion, but never in V3, and particularly not in males. Maybe females, V1, V2, but hardly ever in V3. So that was a red flag. Also, he presented with VT. Now, a left bundle branch VT in a young person. If it's from the outflow tract, you may not worry, but this was not from the outflow tract. It was superior axis, therefore red flag. So if you see VT in a young person, it may be benign, it may be malignant. And this ECG is not normal. So we put him on an exercise treadmill test. We only saw non-sustained VT of a left bundle branch block, in this case left inferior axis. The echo was normal, showed a normal left ventricle, mildly dilated RV with hypokinesia of the free wall. We got a cardiac MRI that showed a mildly dilated RV with hypokinetic free wall, and then treated with a beta blocker and received a dual chamber ICD. So the diagnosis at that point was made based on the VT, the abnormal ECG, and the abnormal imaging. So he met major criteria. 11 months later, within a few hours, he had many shocks. It was 11 shocks, yes, there you go. After a fight in the pub, he got in a brawl, typical English pub, a couple of drinks, shock. And this young 24-year-old man had such trauma from receiving the diagnosis of ARVC and receiving a defibrillator. Now his body is not whole anymore, and he has this protrusion on his chest, and he was a buff young man who felt he was, fully healthy and well, and now he's been struck with this reality, unfortunately. So they called me on the phone. It was a weekend, I remember. They called me and said, "Okay, we'll switch him to Sotalol from his small dose bisoprolol," and he was referred for ablation. Fortunately, in the NHS, it takes months to get an ablation. In fact, it took him, I think, 4 months or so to come to arrive at the lab. We're so busy. Even though he'd had 11 shocks, we could still only offer him an ablation several months later, interestingly. Anyway, so in a case of ARVC, you have the option of endocardial first ablation or epicardial and endocardial. We have our data on about 25 patients or so. About half of them do very well with an endocardial only ablation, and the other half needs a redo procedure. So if you want to think of it one way, as if you want to give the patient the best chances of success, you need epicardial endocardial approach. If you want to maybe reduce the risk and maybe get away with the one ablation in a young person without having to add the risk of epicardial access, then you can think of it as such. I'm still really on the fence about whether we need epicardial for every case. We make a decision on a case-by-case basis and discussing with the patient. This young man certainly wanted nothing to do with us. He said, "Get my procedure done," and he wants to have one procedure, and that's that. So we decided to go epicardial endocardial, and here's the access. It was in front of the right ventricle, so it's a very shallow needle access with using some dye, and then the wire crossing. You have to see the wire going all around the silhouette of the heart in two orthogonal views. And here's our sheath. This is the long sheath here being advanced, and you see it doesn't advance very easily. I'm going to let this play a bit. So you don't want to push too hard, so it's not going. This is probably it's not passing through the diaphragm. So we used a short sheath and use an 8 French, then 9 French sheath to upsize, and then use in this case, an Agilis epicardial sheath with a short deflectable sheath. And here you go, it's passing in the epicardial sac. And then we mapped. So we in this case used a three-dimensional mapping system, precision, with the HD grid here in the epicardial sac. You see it sits very nicely around the wall of the heart. It's a 16-pole catheter, and it acquires data quickly. And you never want to leave the sheath, the epicardial sheath, without a catheter in it. So if you're going to map endocardially with the grid, you put the ablation catheter in the sheath, just so you don't leave a sharp edge scraping the wall of the heart with every beat. So what we do when our approach is, if we're going to decide on epicardial, we go epicardial first. Some centers do it the other way around, but if you're ever going to give heparin for the left side of the heart, you want to access the pericardium first, spend an hour there, so that you make sure there's no bleeding, and then you heparinize for the left ventricle. In this case, because it was a right ventricular only approach, RV endo and epi, we weren't going to give heparin anyway, but I still prefer to do epicardial access first. To me, it's the most worrisome part of the procedure, and so it's probably a good idea to get it done when you're fresh and early and you made your decision. You do that and happy that there's no bleeding, everything's under control, then you do your endocardial approach. This is how we've done it. Although I'll show you some data that you could do it exactly the opposite way. Next, here we go. So because this is a pre-recorded case, we have the luxury of showing you the full map, but only in a minute or so. So this is the grid catheter moving around. What you see to the left, I'm not asking you to pay attention to these electrograms. If you're interested, you can see these yellow bars here. They're marking the end of the electrogram. So every time you put the catheter somewhere, it gives you have a voltage and you have a timing. So you can create what you see here to the left. This image here is the activation map within SCAR during paced or sinus rhythm. And what you see to the right, it's in a different projection, is the actual voltage map. So every point you take during mapping for VT and SCAR, structural heart disease, you have to get 2 bits of information. What is the electrogram shape and morphology and amplitude, and its duration, how long it takes, how long the wavefront takes to get through this area. And those two are important bits of information, and they're distinct. They frequently cohabitate, so within SCAR you'll have delay and low voltage, but sometimes they're not. Sometimes you have two large amplitude signals next to each other. You know there's delay between them, but you still want to know that. So this was the activation map, voltage map. Moving on, continuing. And the reason I say that is, look at this activation map down here of the SCAR. It looks like it will only register a signal and give you anything, a purple or other rainbow color, if there's a signal. Down here there was no signal whatsoever, so it registered gray, and that's the same area that you see down here. And we'll pay attention to that spot, because not all low voltage is substrate. Not all low voltage is SCAR. If you look there, you see, if you quickly caught the electrograms, you'll notice that they're very bland, small, low voltage electrograms that could not support a VT circuit. So when you look at a SCAR, it's not all important. You need to determine the timing. Look at the pathophysiology that you're seeing, not just low voltage. And here is in static view, here's a very good example. These are delayed potentials. I'm sure the aficionados of VT in the audience will realize that these are what we call very juicy, interesting looking electrograms. There's abnormal signal taking its time, and the mapping catheters in this location here, up here, and compare that to, so this is the activation map. So purple here is very, very late. White and red is earlier. So this whole area here that you see here, from up here to down here, is all late electrograms, not necessarily low voltage. And if you correlate that here, yes, there is low voltage, but not all of it. For example, this area here is late. If you look here, I'm trying to show, it's hard to see from this angle, but imagine this spot here, compare that to this spot here. Here it's late, and here it's not low voltage. So not all normal voltage is unimportant too. So all of this information you're gathering through the procedure, and that's why you're not just doing the map, going through the motions, you're actually looking. And that's why when you automate map taking is important that you are paying attention, because it'll end up showing you a picture like that to the left and you won't know what to do with it unless you're going to ablate the whole thing, and which we cannot do. So paying attention to the signals is critical. Okay, so here's another example of delayed potentials. I mean, look at this, almost double potentials here, all along the grid, which is sitting right there. Okay, this is just another example. Okay, and here is an area of low voltage, but not substrate. Look at these signals. Nobody would imagine these signals can support VT. They're so tiny, right? There's nothing there. There's no delay. It's just almost like you threw a towel on the signal. It's just either there's poor contact or it's just total dead scar. So not all low voltage is important. So the proponents of ablating the entire scar are really maybe not doing themselves a service or their patients, because you have to pick and choose the spots where you're going to ablate. Okay, in ARVC, we know that when it was first described, it was described as a disease progressing from the epicardium to the endocardium, fibrofatty infiltration that goes in that direction. In fact, when it was first described in the 1970s, the surgeon, I think it was Giraudon, opened up the right ventricles. A gentleman with VT opened the RV, and his comment was that the RV endocardially was normal. And it was only fat on the outside of that. They dislocated the RV. They basically sliced the anterior wall and sewed it back together again. The patient never had VT and died 20-something years later of something else by just cutting the RV through and through and reattaching it. Anyway, so knowing that we have epicardium and endocardium, two different surfaces, we want to interrogate from the endocardial surface. If you're doing an endocardial only procedure, can you tell that there's an abnormality on the epicardium without going to the epicardium to tell you whether I need to go or not? So there is hope in measuring unipolar electrogram. So this is the RV endocardial bipolar versus unipolar low voltage areas. This is the bipolar low voltage area. Anything other than purple is abnormal. And this is the unipolar low voltage area from the RV endocardium, looking in RAO. So you see that all of this gray is low voltage. And if I give you some numbers, it's 14 centimeters squared for the bipolar abnormal area endocardially, and 90 centimeters squared for the unipolar abnormal area. Now, a group in Barcelona has looked at these numbers with interest, and they found in their data, although this is not everywhere and not necessarily in our data, if this figure is above 23%, so what is 10% of 90 is 9, so 18 is 20%, so less than 18, 20 would indicate, if it's greater than 18 or 20, would indicate that the epicardium is more involved. And if it's less than that, it may tell you that this figure here is well under, it's 15%. It would indicate that it's probably the epicardial surface is more involved. If it's greater than that, greater than 23%, you may be able to ablate endocardially, meaning it is so advanced that now the scar has progressed to the endocardium enough that the figure, the endocardial abnormal figure, is so high relative to the epicardial, the unipolar signal, that you probably can ablate endocardially and get success. And in their data, they showed that if you use that number, you may avoid epicardial ablation and mapping. And in fact, in one of their cases, they had a death from epicardial puncture that the patient didn't need epicardial ablation. So they're trying to persuade us to use this, although I can show you a case in which this didn't work out of 25 cases. So we haven't measured this in every case, but the few I have measured, it's worked on a couple only. Anyway, these data indicate that it is epicardial substrate. So this is RV endocardial bipolar versus epicardial bipolar low voltage. And you see here, this is the small area of scar that I talked about, 14 centimeters squared. And this is the epicardium low voltage. Look at that. And that correlates with the unipolar abnormal signals. Am I gone beyond the time? I still have 17 minutes. Oh, okay. Okay. Oh, thank you. I need 10 more minutes. Thank you. Thank you. Okay, so moving on. So if you look at the epicardial bipolar low voltage, it correlates with the unipolar endocardial data. Okay, we've beat this point up. And here I want to show you a good example. This is the an area on the epicardium that shows delayed potentials. But the endocardial surface, which is where the grid is on the endocardium, it shows you no late potentials. So meaning you can have the RV wall, we think of it as thin, but in ARVC cases, in fact, you can have both surfaces telling you two different stories. The epicardium here was to blame. The endocardium had normal signals, and this is. So this is the area of abnormal signals, showing it by activation map, and this is by voltage map. This is just a way to show the delay of signals. So this is the activation sequence in a sparkle fashion. It's a little bit of a gizmo that the companies have. They all have their different ways of showing it. It just draws your attention to the latest potentials activating up there. Okay, that's all you need to know about that. Okay, getting into real electrophysiology now. So when we do VT stimulation, program stimulation in ARVC, we not only are looking for sustained monomorphic VT, we're also looking for these responses. Non-sustained VT, we typically don't use that, but in ARVC I would urge you to put your catheter where the scar is and interrogate whatever you see. 2, 3, 4 beats may give you data. This here definitely gave us data. The electrograms here are not passive. There's for every one QRS, there's more than one potential on the electrograms. If I blow this up, you'll see that it's almost using this area of scar as an area of reentry. This is just undeveloped VT, but if left to its devices or with isoprenolone, it will continue. And you'll notice here that lead 1 is positive, lead 2 is negative. So this is not an outflow tract VT. This is something else. And I want you to pay attention to these 3 beats, okay? I'm going to blow them up. The grid here is on the epicardial RVOT. And I think for those of you who are really interested, this will be the most fascinating slide. I don't think I've seen anything like this published, in fact. But take a look at the first beat. This is a PVC. And you see the local electrograms on map on the grid precede the QRS by 104 milliseconds, if I can see correctly, okay? So that makes sense, it's a PVC. What's the big deal? So what's the next event that you see here? Now, if I were in a workshop, I would ask a fellow, but I'm just asking the audience in general. Everybody ask yourselves what you're seeing here. I'm going to give you 1, 2, 5 seconds to think. Correct. Dr. Mirvat, of course. This is a local automaticity that does not affect the QRS and has had no time, 50, 60 milliseconds, to get out. So on the previous beat, it had time, it gave you a PVC. Here, the sinus beat, or the pace beat had come through, sinus in fact, had come through before it had time. It needed another 40 milliseconds to exit, but it didn't. And the next one is doing the same thing. See these sharp potentials? These are local activation that is impossible to happen before the QRS, right? If it has to be later than the QRS. So you're going to see far field first, then near field. So your eye has to be drawn. These are abnormal potentials. This is local activation. This is highly active abnormal scar. And I'm going to compare this. So this is a VE. The first one is a VE. The first one is a fusion beat. In fact, the QRS is slightly off. If you really look at V1, you'll see a little Q wave. It starts with, so there was a little bit of exit, but this next one, there was nothing at all. So you have abnormal automaticity, epicardial low RVOT, local EGMs V to QRS is 104, local EGM to intrinsic QRS 60 milliseconds. It has no time to exit. And I'll tell you, this is critical. If you're interested in VT mapping, this is the sort of detail you want to get down to. And here's a very good example of local firing. And then here, the far field followed, far field followed by near field. Okay, so it's very different. Look at these two sequences. One is 1, 2, then 2, 1. Okay, critical to notice this stuff. If you don't see this, you're not going to ablate VT. And here's the VT, the left bundle, left superior morphology we induced in this young man, program stimulation and isoprenolone, which is frequently needed. The tachycardia cycle length is 291 milliseconds. This is a very abnormal rhythm. V1 to V6, it's concordant, so it's fairly apical in the RV, or at least on the RV free wall down low, because 2, 3, and AVF are negative. And here's a quick activation sequence. You'll see this is a propagation map. You see on the grid, you see it kind of goes around in a loop, and then kind of you almost see like there's a bit of an exit or a channel there. And here are the local electrograms. Look at these mid-diastolic potentials here. It really is nice to have a multipolar catheter that can really quickly detect this data rather than point by point. We now have 16 poles and more that you can interrogate. And here's another form of propagation map. You can kind of see almost an exit or a channel. It's going through there. The whole sequence, the whole cycle length is going through that area. And here we note during sustained monomorphic VT, their mid-diastolic potential, 68 milliseconds pre-QRS. And I put a question mark because I put it there. I think it's there. It's almost just at the level of the noise. And here we have a stim to QRS, so we pace during VT, stim to QRS shorter than EGM to QRS. That, if that happens, then you're not in, you're capturing some other distant tissue. And I'm asking you a question. We're in training, it is a concealed or manifest, and not to belabor this point, look at V6 here. It's positive during pacing, but negative during VT. So it's entrainment with manifest fusion. It's not a good spot. However, as published in the Egyptian Heart Journal at some point, 2017, that if this is the wall of ARVC, you could see there's fibrofatty infiltration, Masson's trichrome stain here. You can see that this is the endocardium, epicardium is this way. Clearly, if the VT is utilizing this part of the myocardium and you're pacing high output, you could potentially capture other myocardium. There are layers in ARVC, and I think this is important to realize. You may not get exactly the data you want, but you have to put everything together. So I use this just to give an example that you may very well capture more than one strand, depending on what your how high output. And in fact, because of the fatty infiltration, you may have to use high output to capture the tissue. Again, mid-diastolic potentials here all over the place. You can see, take your pick here. The tachycycle length there, and 65 milliseconds pre-QRS. This is pretty good, and because the blood pressure was getting low, we anti-tachycardia paced them out of the circuit just to give him a breath for a few minutes, and we remapped that area. We found these delayed potentials here, and we re-induced the VT just because we could, and we had the luxury of doing so, and we found an even better spot here with a beautiful pre-systolic potential, mid-diastolic potential. And this is where we found it on the RV free wall. This is our mapping catheter, and before we ablate, we have to perform a coronary angiogram, because lest there be a coronary that crosses your path. Fortunately, in his case, there was no major epicardial coronary artery, and we ablated. And this is our first ablation lesion. RF energy on, VT off. Okay, this is not pretending. This is it. It's just a few seconds long. I think it was 5.7 seconds. It terminated, and it's our first ablation lesion. Even though at that point we had entrainment with manifest fusion, but everything else looked correct. We had enough data to say that this is, if not exactly the exit, it's involved, maybe we were capturing some deep tissue. There was wobble in the VT cycle length during RF delivery, which is typical of this, which means you're affecting the circuit. And here's the termination. The TCL lengthens pre-termination, and we got it. And I want to draw your attention to this area of SCAR. Here, this is the SCAR activation map. Remember, this was relatively preserved voltage, but it was late. But here on the SCAR area, it was not SCAR. It was actually preserved voltage. Okay, so it's delay without low voltage. And here are the ablation lesions. Okay, if I were to say I'm going to ablate the entire scar, we would have had 3 times these blue red tags. So this was strategic placement of lesions rather than ablating the entire scar. It's been now 6-7 months. He hasn't had VT. I think we got success. This is his ECG post-op, and that's what I wanted to say. One last thing, this is another ARVC case where we were ablating, just to make the point of epicardial versus endocardial ablation. This is a gentleman with an outflow tract VT, outflow tract scar here, with the grid again, outflow tract endo and epi. Because the epicardial scar was close enough to the LAD that I decided it's probably not a good idea to ablate there too much. So we said, let's try to ablate this endocardially. So grid overlying the epicardial surface of the RV outflow tract, and we're ablating endocardially opposite that area, which was also abnormal endocardially. And I want you to watch this video, see what happens to the signal. I'm going to go back for a second just to start it. So see how closely it's married to the QRS. Just look at this interval, QRS to the near field late electrogram. Just watch that as we ablate, okay? See how it immediately went out? It opened up a bit, that signal. And I'm going to show you even more impressive. As we continue ablating, it gets more fractionated. And watch this, gone. Endocardial RF ablation dealing with epicardial outflow tract scar. In fact, a member of the audience here, our fellow for a year, published this in, I think, JCE a few months ago. Majority of RFA was endocardial, no RVOT, epi RFA was needed in this case, and limited epi RFA at the basal RV down here in a safe location, and he was non-inducible. He came back a few days later with the chest pain, significant chest pain. We had to give him colchicine for it, pericarditic. But he was fine, echo was normal. Just, I'm giving you a bit of follow. Anyway, thank you.